want to thank Socially Distance, or SDS, sorry, I'll use the abbreviation. Socially Distant Showers for the opportunity. This is an awesome turnout. The fact that almost 300 of you guys are here is very flattering. I'm honored to speak for you guys. So I'm going to share my screen here. Let's see. All right. So maybe if someone could give just a thumbs up that you guys can share my screen. Awesome. So the way we're going to format this is I prepared this slide deck for you guys. First, I just want to introduce who I am so you guys have a sense of my background. I'll tell you a little bit about the field of neurosurgery. Again, I'm just a resident, so there are people much more experienced in the field of neurosurgery, but I can tell you what drew me to the field and some awesome aspects of what I do every single day. And then I want to take you guys through a little case lesson, a little primer of kind of a basic neurosurgery concept to give you guys a little small taste of what we do and what we deal with on a daily basis. So again, my name is Alex Schupper. I'm a second-year neurosurgery resident here at Mount Sinai. We are the largest neurosurgery program by volume in New York City. We're one of the largest programs in the country. As far as my background, I grew up outside Philadelphia in Lower Merion, and then I had the opportunity to go to Johns Hopkins University for undergrad, where I double majored in neuroscience and psychology, which is really where I was exposed to the field of neuroscience. I grew up in the home of a father who was a surgeon, and I knew I wanted to be a surgeon from day one. I was one of those weird people. I always liked building things, using my hands, and that was the side of medicine that always appealed to me. Then when I was at Hopkins, I had the opportunity to work with Nobel laureates in the neurosciences. I got to shadow Ben Carson in the operating room, work with some of the most well-accomplished neurosurgeons in the world, and I just fell in love. And after that, you couldn't convince me to do anything else. So it's kind of a basic path to neurosurgery, but for me, it was very linear. I had the opportunity to play varsity baseball at Hopkins, which was an awesome experience. I can't speak enough about college athletics and just being part of a team and how much that correlates to the field of medicine. Additionally, I was the student government president when I was at Hopkins. I really loved that time collaborating with other students in different groups and improving our student life while in college. And then I conducted both neurosurgery and trauma research. Again, I knew I was interested in surgery, and specifically neurosurgery, and I wanted to delve more into the research side just to learn more about the field. So I then took a big turn and left the East Coast and went out to sunny San Diego for a medical school. This is for a couple reasons, but I wanted to get away from the East Coast. I spent my whole life within 100 miles of home and just wanted to experience something new. UC San Diego at the time had a very famous chairman of neurosurgery who named Bob Carter, who has been a pioneer in glioma research, which is, it was a significant part of my research during undergrad. And so I wanted to pursue that research. So I ended up going out to San Diego. I worked in his lab for a few years. I lived by the ocean. I learned to surf, and I had a really great experience. And then I've pursued a lot of my the same hobbies that I established in San Diego and even earlier in my life during residency. It's often challenging, and people ask me all the time how I keep up with these hobbies, and it's all time management. We all have 24 hours a day. It doesn't matter if you're operating for 18 of them or, if you don't have that much going on. You can always pursue your hobbies. They just have to be important enough to you and make it a high enough of a priority. So for me, things that keep me going and make me excited to wake up every day besides doing surgery is I'm an avid CrossFitter. I love doing CrossFit. I actually just did a workout about an hour and a half ago. I love hiking. I love going outside. I love seeing nature and its beauty. I love snowboarding. I just came back from a snowboarding trip last week with one of my co-residents, which you can see here in the lower right panel. I also love traveling. I love seeing the world. Unfortunately, now with COVID, it's a little bit more limited, but we've done some cool trips recently. That's Borobudur up there in the top right, which is one of the most beautiful things I've ever seen in Indonesia. And then I love cooking as well, both from a health perspective as well as financially. It's a lot easier to cook, especially in New York City. So again, like during the introduction that was mentioned, I have many clinical interests. I really love all aspects of neurosurgery, which I'll talk to you about in a sec, but some big interests of mine are complex spine surgery, such as deformity surgery. Additionally, I love brain tumor surgery. We can make such a difference in people's lives. We deal with really tough diseases like glioblastoma, but from a surgical standpoint, we can really improve the longevity and the quality of people's lives. And so it really is a privilege to be able to treat patients with these diseases. Additionally, I love pediatrics. pediatrics is its own beast in itself. Kids have different types of brain tumors. They have different types of syndromes, a lot of genetic syndromes that we can often make a huge difference in their lives. And unlike adults, when you can improve the quality of life in a child, that can correlate to decades and decades of improved quality of life. So we can really make a large impact in our pediatric population. So why neurosurgery? I gave you guys a little bit of an intro as far as what I like in the field. But the first thing I want to talk to you about is that people have this misconception that neurosurgery is just the brain. All we do is operate on the brain. Well, there's a very famous quote from a UCLA neuroscientist named Arnold Scheibel that his quote is, "You are your nervous system." Every part of your body is your nervous system. That's something you have to remember. This image here to the right shows your nervous system. And it really looks similar to your whole body, because the truth is, wherever your blood vessels are, there are nerves. Your spine and your spinal cord control the movement sensation of your entire body. So we really are a nervous system. And as surgeons, we operate on the entire body. I can operate on the nerve on someone's foot or outside someone's eye. So we really operate on the entire body, which is an awesome part of neurosurgery. Again, so the definition is that we're the specialty that deals with the surgical management of neurological diseases and disorders. We operate not just on the brain, but the spine, as well as the peripheral nervous system, which involves your entire body. Now we're divided into several subspecialties. There's some main subspecialties and some smaller ones. Again, these are them all listed here. Spine surgery by volume is the largest. We're about 70% spinal disorders, just by sheer number. Neurosurgical oncology includes both brain and spine tumors, specifically spinal cord tumors. We also have other areas of the field like skull base surgery. This includes anterior skull base, such as pituitary surgery, or middle skull base, which can include different types of tumors, most commonly acoustic neuromas or meningiomas. Again, I already mentioned pediatrics. We also have functional neurosurgery, which is one of the growing areas of the field. You guys have heard of things like DBS, or deep brain stimulation surgery, or epilepsy surgery for people with seizures. This is a very big growing field. There are also new targets now. I don't know if you guys have seen it in the news, but now we're using things like DBS to treat depression, to treat obsessive compulsive disorder, and different psychiatric diseases. So it's really an interesting field. It's a very exciting time in neurosurgery. And then finally, peripheral nerve. So there are a lot of different areas of the field of neurosurgery. So these are just some pictures here. You can see in the top left panel, this is a pediatric patient who has something called ATRT, or atypical teratoid rhabdoid tumor. It's a very severe malignant tumor. It's very fast growing. And then in the bottom left-hand corner, you can see someone with a severe scoliosis that was corrected with instrumentation with rods and screws. And then in the bottom right-hand panel, you can see a cartoon depiction of AVM, or an arteriovenous malformation, which is an abnormal collection of blood vessels within the brain or any part of the body, but we specifically operate on these in the brain. So neurosurgery really runs the gamut. There isn't one thing that we treat. It's a very diverse specialty. It's very challenging, but it's extremely rewarding. So off on that note, I wanted to talk to you guys about some things, both the facts and the misconceptions of neurosurgery. So some facts, as I just mentioned, it's a very diverse field. We operate on everything from the head to the toe. Any part of the nervous system that needs surgical intervention, we handle. It's technically very challenging. Everyone says, oh, you must have great hands, you're a neurosurgeon. Well, you can train your hands, but at the same time, you do need some innate aptitude just to be good with your hands, be able to use your hands and feel comfortable in the operating room. Because in neurosurgery, for us, a millimeter is a mile, right? The difference between someone having a great outcome or removing all the tumor versus giving someone a deficit after surgery can be, less than a millimeter. So for us, precision is everything. You need a very strong research component in neurosurgery. We're a very academic field by nature, similar to a lot of other surgical subspecialties. We have a very high interest in research and publications. If you look at the neurosurgery match for last year, we routinely, our accepted applicants to neurosurgery have some of the highest numbers of publications in the country. So you have to have an interest in neurosurgery, in neurosurgery research to go into the field. It's incredibly rewarding. As I was talking about earlier, there are so many, I have countless stories of numbers of patients who have inspired me and changed my life, both from newborn babies who we've taken out brain tumors from, to 90-year-olds who have fallen and have bleed in their head that we've evacuated and saved their life. So it's incredibly rewarding. Every single day we make a difference in people's lives. And for me, that's what keeps me going. And that's what makes the long days short, and why I never feel like I'm truly going to work, because I love what I do. And then it is true, it's a very well compensated field. Neurosurgeons all do very well, similar to a lot of areas in surgery, but it's, again, it's not why you go into the field, but you do know that if you become a neurosurgeon, that financially you don't have to worry, at least in this country. Now, so this is just showing kind of some of the technology and some of the stuff that we have. In the top left-hand panel is something called the exoscope. So it's a new visualization technique that we use instead of a microscope. I don't know if you guys have seen the new Netflix series Lenox Hill, but they use the exoscope as well. It's our partners down the street. It's a really cool new way of visualization in the operating room. There's a huge flat screen TV that we can see everything with really high resolution. And then you see a big suprasellar tumor here in the top right-hand side. Now, some misconceptions I want to talk to you guys about neurosurgery. I feel like we're one of those fields that often gets misrepresented. So not all of our patients are asleep. You know, a lot of people say that neurosurgery patients are so sick, they're often comatose. There are a lot of misnomers as far as patients in the neuro ICU. That's not true. We often have patients who have very severe neurological injuries, some of which are non-recoverable, but this is definitely not the majority of our patients. Again, another misconception is that only the top medical students at the top med schools can become neurosurgeons. It's not true. While we all tend to do well on our boards and are very productive from a research standpoint, I know people who went to DO med schools, people who are not top of their class in med school, who found a way to get into neurosurgery. The moral of the story is, if you want and you're willing to work hard enough for it, you can be a neurosurgeon. As long as you're motivated and you're willing to find a way in, that's what we look for, more than just someone who has the innate aptitude. There are also a lot of misconceptions, like women, certain minority groups can't become neurosurgeons. That's not true at all. While by numbers, we are more of a male favored specialty, similar to a lot of surgical specialties, with the exception of OBGYN. Women absolutely can become neurosurgeons. Some of the best neurosurgeons I know are women. And to be honest, nowadays, as someone who's now on the residency side, who is actually recruiting our next class every single year, we often look for strong women ahead of men, because we want to even that balance. We want to make it closer to 50-50 and not make it so male dominated. So if you're a woman interested in neurosurgery, I highly recommend it. You're going to be very sought after in the field of neurosurgery. So I can't recommend women to go into the field enough. And then the last misconception is Grey's Anatomy. It isn't always like Dr. Shepard. You know, we're not hanging out in the call room all day long, just being very attractive. Neurosurgery is a very demanding field, but I think the perception from Grey's Anatomy isn't always true. So take that with a grain of salt. All right, so as far as my path to neurosurgery, I talked to you guys a little bit about it. I started in West Philadelphia, born and raised. You catch the joke. Went over to Baltimore to Hopkins, went all the way west to San Diego, and then finally circled back here to New York City to be at Mount Sinai. So I've really come full circle, but through that, I've had a great perspective as far as seeing some amazing hospitals around the country and seeing how different departments work. So now I want to give you guys a little lesson. Let me see how we're doing on time. We're doing okay. Intracranial pressure management. Now, I'm not expecting you guys to know the answers to these. Again, this is just to give you guys a small taste of what neurosurgery is like and something we deal with on an everyday basis. Now, again, I'll use the acronym ICP. It stands for intracranial pressure. So it's just a little case situation. You're a neurosurgeon, you're working in the emergency department, or you're called to the emergency department because a 35-year-old guy just got in a really bad car crash. He was speeding, going 75 miles an hour, no witnesses. The paramedics picked him up. He's just mumbling and confused. When you see him, he starts vomiting a couple times. The NBMB is non-bloody or non-bilious emesis. Emesis is just a fancy word for vomiting. So these are his vital signs. You can see he's a little tachycardic. His blood pressure is around normal. And he's saying okay at 96%. So the question is, what's your next step, right? So they're going to call you. They're going to say, hey, there's this guy, he's mumbling. There's something going on. You know, maybe something in his head. I'm not really sure. What do I do next? So we want to make this as interactive as possible. I know the chat is pretty active, But just as far as oops, sorry about that. Just as far as things to do next is you want to examine the patient, right? When someone calls you, and this applies to any field of medicine, someone calls you, and the reason they're calling you is because they don't know what's going on, and because you're a specialist most of the time in these situations, and you want to help them. So the best thing to do is go see the patient, right? You never want to rely on anyone else. You always want to trust your own exam, your own skills as a physician or a surgeon, and you want to trust your own exam. So the first thing I do is I say, all right, thank you. I'll be right down to see this patient. So I go down as neurosurgeons, while we care about the cardiac and the respiratory exam and the abdominal exam, what's most important to me in terms of what I'm going to do as a neurosurgeon is his neurological exam in this case. So his neurological exam in the case of trauma, we want to use something called a GCS. Now GCS, I'm not sure if you guys have heard of it. It's a Glasgow Coma Scale. Essentially, it's a scale of consciousness. Now, right now, I'm hoping that most of you guys, unless you're asleep, are a GCS of 15. That's the maximum. That's the highest level of GCS. It goes all the way down to a 3, which is the lowest possible GCS. Essentially, you're comatose at that point. Now, it's separated into 3 components: eyes, verbal, and motor, which we're going to go through in a sec. But this guy is a GCS of 8, which is pretty low, actually. So what this is chalked up to mean in this case, in plain English, is that his eyes open to noxious stimuli. This means when you call him, you say, hey, Mr. Smith, he doesn't open his eyes. But when you give him a sternal rub or give him some stimulus to help wake him up, he'll open his eyes. He's moaning. He's not really making coherent sentences. He's not saying any words that are English or any language that you're familiar with. He's just kind of moaning there in the stretcher. You look at his pupils. Now, in this case, I want you guys to pay a lot of attention to this. Most people's pupils are the same, meaning their left pupil and their right pupil are going to be the same size. Now, this guy, one of them is sluggish, meaning when I shine a light to his eye, it gets smaller very slowly. Now, the other one is brisk. What that means is we shine a light and it collapses right away, which is normal. That's a normal response. Now, we also want to test certain things called brainstem reflexes. There are certain reflexes that if you have an intact brainstem, which is the bottom part of your brain that connects the spinal cord, if that's working well, you'll have certain reflexes. Certain reflexes include a cough or a gag. For example, if you stick a tube down someone's throat, they're going to gag. That's just a reflexive response. It's nothing you do volitionally. Additionally, they'll have something called a corneal reflex, where if you rub a soft object on someone's eyelid, they'll blink automatically or their eyelid will close. Again, that's a reflex coming from the brainstem. These are all things we can test at the bedside. Now, when we examine this guy, he has something called extensor posturing in both the left upper extremity, the left arm, as well as the left leg. Now, what this means is that his left arm is both extended and pronating, okay? Now, this is a response that we'll talk about a little bit later, but this isn't a normal response. If you see someone that is quote unquote posturing, that's often a bad sign, okay? And it's a sign that the patient might be moving in the wrong direction in this setting. Now, this patient is not following commands, meaning when you say, hey, Mr. Smith, show me 2 fingers, he's not doing it. So this is kind of his basic exam. So I spent a little while going through that because I want you guys to be familiar with what we look for as neuro specialists, whether you're a neurologist, a neurosurgeon, a neuro-oncologist. This is the basic neurological exam in someone who comes in following a trauma. So again, this is kind of the breakdown of the GCS. I'm not going to spend too much time just for time purposes going through it, but it's based off a 15-point scale. Maximum is 4, 5, 6 for eyes, verbal, and motor, which is how you are right now. And the minimum response for each is a 1. So he's an 8, which is actually pretty low. So the next step is, one important thing I want to talk to you guys about before we get to this are the ABCs. Now, something that is very common that I see with a lot of our medical students is they only think in terms of being a neurosurgeon. They forget that they're a doctor for a second. But what's really important, what you have to remember, is before you're that specialist, you're a doctor, right? So for a guy like this who's coming in, who's not responding well, not verbalizing well, he's extensor posturing with a GCS of 8, the first thing that this guy needs is a tube down his throat. There's an acronym in trauma that says GCS 8 intubate. This guy needs a breathing tube because he's not going to be able to continue to sustain his airway very long. And while we think the brain's very important in neurosurgery, if the guy's not breathing and his heart isn't working, his brain's not going to be very healthy either. So what the moral of this brief story is, you're a doctor before you're a specialist, in this case before a neurosurgeon. So this guy needs to be intubated. Now, once he's intubated and his airway is stable and we've stabilized any other severe injuries at this time, then he needs to go for a CAT scan. And this guy needs an urgent CAT scan because there are some very concerning findings on his exam. A, his pupils are not equal. He has something called anesicoria. His pupils are not symmetric. Additionally, one is responding quicker than the other, and he's posturing on one side of his body. Now, as a neurosurgeon, this makes me think that there's probably something going on in his head. Now, I'll give you guys the answer. So I'll save you guys the time for the chat. If he's posturing on one side of his body, he's most likely has pathology on the other side of his head. It's just how the brain is wired. Everything is wired backwards because the white matter tracks cross, so that the motor response on one side of the body is carried out from, or the signals are brought from the opposite side of the brain. So if he's extensor posturing on the left, he most likely has something wrong on the right side of his brain. And so we get a CAT scan of this patient. This is what it shows. Now, I'm sure a lot of you guys can identify that there's something wrong going on here. This isn't what a normal CAT scan looks like. I don't have a normal CAT scan next to it, but you'll have to take my word for it, that there's something wrong with this guy's head. Now, if you guys look at the left side of the picture is the right side of this guy's head. And if you see that bright crescent line going down, that's blood. When you have a bright signal on a CAT scan, that can be a couple things, but in this case, it's most commonly blood, and not just blood, but acute blood, meaning blood that is new, that's only been there for maybe a couple hours, okay? The white rim around his bone, that's his skull, and then the gray stuff in the middle is his brain. The black lines are the CSF spaces, or the ventricles, which contain the cerebral spinal fluid. So I'll just tell you, this guy has a severe acute right-sided subdural hematoma. So that means the blood is underneath the dura on top of the brain. So the blood's not actually in the brain, but as you can see here, it's pressing on the brain. So if you guys see those two little C shapes that are black in the middle, if you can appreciate how those are pushed over to one side, that's called midline shift. That's because all that blood is causing so much pressure on the brain that the brain isn't able to compensate, and it's pressing those fluid-filled spaces over, which is very severe in the acute setting. You can die very easily from this. So again, we talked about this. This is an acute subdural hematoma. Now the next steps, again, we've already intubated him. All right, we've controlled his airway. This guy needs surgery. This is not something that we can sit on. This is the type of injury that if we wait on this guy could possibly die. Now, the reason for that is something very simple called the Monroe-Kelly doctrine. If you guys have never heard of it, I guarantee you've understood this concept. Think of the head as an enclosed box. It's a box that's locked up. There are only a couple things inside this box, okay? One is the brain, pretty obvious. The other is blood. We know that. There's blood in the brain, right? You have blood vessels perfusing the brain and making your neurons happy. The third thing is the cerebral spinal fluid, those black spaces that we saw. Those are the only three things allowed in the brain, and they're in set volumes, okay? So because the head is an enclosed space and we're not increasing the volume, as you add more and more things inside, the pressure is gonna go up because you have a fixed volume, right? It's basic physics 101, what you guys learn in college. So it's the same thing here in the head. So as long as the space stays enclosed, the pressure is going to go up as we include more things, which is in this case blood. The same concept applies for an infection in the brain, for a tumor in the brain. These are all things that can increase the pressure. Now we can talk later about cerebral autoregulation. That gets a little bit more high level, but that's also something that can determine what we do. Basically, the gist of this slide is that you have this happy zone where within a certain range of pressures within the head, your brain is very good at auto-regulating, which means that it will normalize the amount of blood flow to the brain within a range of pressures. However, as the pressure goes up and up and up, eventually it's not going to be able to sustain this level of auto-regulation and the swelling is going to worsen, which is going to worsen the patient's prognosis. So the reason it matters is, why we care about this, why we're freaking out, rushing this guy to the operating room, is something called herniation. Now, I'm not sure if you guys have heard of herniation before. If you haven't, you've probably heard of a word called hernia. It's the same thing. So you've probably seen something like this. This is an umbilical hernia, very common. A lot of people have hernias. You probably know someone who's had a hernia, whether it's been repaired or not. Well, let me tell you this, a hernia in the belly that general surgeons deal with is the same concept as herniation in the brain. So this is cerebral herniation. Essentially, it's because of increased pressure in an enclosed space, which is the skull. It's going to cause movement of the brain to an area it's not supposed to be, or herniation. It's creating a hernia, essentially, of the brain into a space it's not supposed to be. Now, this can go in several different ways, but the gist of this is that if the brain herniates and it impinges upon the brainstem, the patient will die. You cannot survive with increased pressure on the brainstem, right? Because keep in mind, the brainstem is what controls your most vital functions, your ability to breathe, your ability of your heart to beat. All of these regulatory things are controlled through your brainstem. So without an intact brainstem, the patient won't be able to survive. So just a reminder, let's see how we're doing on time. We're at half an hour. All right, keep moving. So there are main causes of high pressure in the head, okay? So in this case, this is a trauma, right? The guy got into a bad car accident, but there are also other causes that we often see. One of them is brain tumors, infection. There are a lot of different causes, demyelinating diseases, something called hydrocephalus, or increased pressure in the head, okay? These are all causes of increased pressure. Let's see. So I'm just reading this poll, very interesting. Let me count the I like it. All right. So the big take home for ICP management that I want you guys to know is that it's a stepwise approach. So a lot of things we can do to decrease the pressure in the head. Now, the first thing that I want you guys to know is that before giving any medicine or doing any surgery, there's a lot that you can do as a pre-med student, as a medical student, as a resident, to decrease the pressure inside someone's head. So again, we talked about airway management. You have to remember your ABCs. Before we do any of this, you have to secure their breathing, right? If the patient can't breathe, none of this matters. Now, just positioning the patient actually can decrease the pressure in their head by a significant amount. The first thing is lifting their head up. The thing I hate the most is I go down to the trauma bay and I see the patient, they're totally laying flat. I'm like, if you're worried about high intracranial pressure, why are you laying this patient flat? Just lift their head up. By lifting their head up, you're encouraging blood to leave their head, right? Same thing, if you hold your arm down low, your veins are going to get bigger, right? Because blood is going to start pooling down in your arm. It's the same thing in your head. Okay, you want to keep the head midline. That's because you have two jugular veins, one on either side of your neck, that allow blood to leave the head. If the head is turned, that's actually collapsing one of those veins and making it harder for blood to leave the head. And again, a lot of these patients will be in a C-collar, a cervical collar after trauma. You want to loosen that actually for the same reason, so you're not collapsing those veins. You want, after they're intubated and you have their airway secured, you want to sedate the patient. Okay, that's just to decrease the metabolic rate in the head. That will also decrease the pressure. And again, we have to get imaging. As surgeons, we don't have a magic 8-ball. We can't see what's in their head. We don't have some invisible glasses that can see. We need a CAT scan, at least initially. So again, the picture on the right is a acute subdural hematoma. On the other side, actually, the case I showed you. And then the picture on the left is something called an epidural hematoma, which is similar, but it's in a different space. It's actually outside of the dura, which is the lining outside of the brain. An easy way to tell the difference, and in med school, I'll guarantee you'll get pimped by some of your professors on this, is that an epidural hematoma does not cross the cranial suture lines, and it'll look more of this kind of eggshell shape. And then a subdural hematoma does not obey suture lines because it's underneath the dura. So it can expand the whole hemisphere, as you see here. So after we do all those basic maneuvers to try to decrease pressure, there are a couple other things we can do. We can give them something called hyperosmolar therapy. Now, you guys might not be familiar with some of these medicines, but they're really powerful medicines. One is very simple. One is something called sodium chloride or salt. However, if you give someone a very concentrated solution of salt, like 3% or even 23.4%, essentially what it does is it sucks all the water outside the head because it creates a sodium gradient in the bloodstream that will decrease the pressure in the head by decreasing the water in the brain. Your brain is mostly water by weight and volume. So by sucking all the water out, it'll decrease the pressure inside the head, and it will leave more room for that blood that has now entered the brain. Additionally, there's something called mannitol, okay, which is an osmotic diuretic. It does the same thing essentially. Essentially, it creates a gradient for water to come out of the brain. You have to be very careful with mannitol. It can wreck your kidneys very easily. So if a patient has kidney disease, you want to be very careful with giving this drug. And then again, there are other causes of high intracranial pressure. If they're having high ICPs because of something like a malignant brain tumor causing a lot of swelling, you don't want to give them necessarily only hyperosmolar therapy. You'll want to give them something called steroids, because the reason the brain tumor is causing so much swelling in the head is because of something called vasogenic edema or edema surrounding the tumor. So steroids will actually help with this. And along those same lines, in the case of infection, like an intracranial abscess, you want to give antibiotics to treat the infection. Now, where we come in as neurosurgeons is going back to that slide on the Monroe-Kelly doctrine, that the head is in an enclosed space, that the brain is in an enclosed box called the skull. What we do is we reverse that effect. So what we do is we take the bone off the skull to free that pressure. Essentially, we create an infinite volume by opening up the skull so that there is an increased pressure inside the head, so the brain can actually come out toward this infinite volume that we've now created. So that's called surgical decompression. Depending on where the site of the bleeding is, we can do something up here called a hemicraniectomy, where we remove half of the skull. If it is down at the bottom in the place called the cerebellum, or by the brainstem, what we can do is a similar type of surgery where we remove the bone, except we do it really at the base of the neck, and that's called a suboccipital craniectomy. Same purpose, just in different parts of the head. Another thing we can do, again, going back to the Monroe-Kelly doctrine, is we can take off the fluid. So in addition, or as an alternative to taking the bone off to create this infinite volume, what we can do is we can decrease the other substances inside of the head. So obviously we can't decrease the brain, we can't just take the brain out, but what we can do is decrease the amount of CSF or cerebrospinal fluid inside the head, and we can do that by placing a drain that takes the fluid out. And this is a picture right here. It's called an EVD, or an external ventricular drain. I'm actually about to scrub into a case in a couple minutes where I'm about to put a permanent version of this into a patient's head, which is called a shunt, or a ventriculoperitoneal shunt, which is just a permanent version of this here. Now, if all these things don't work and the patient still has high ICPs, we still have to treat it, because if we don't treat the high ICPs, the patient's going to die. So it's a very severe thing. Some other alternatives, if surgical decompression doesn't work, or if hyperosmolar therapy doesn't work, we can paralyze the patient. For the same reason as sedating them initially, creating paralysis, so giving them a drug that stops their ability to move essentially any part of their body, it decreases how much energy the brain is using, which will also decrease the pressure inside of the head. And then as a final last-ditch option that we refrain from unless we absolutely need it is something called a barbiturate coma, where we can put them in a pentobarbital coma. Now, again, this is the last thing we want to do. There are a lot of potential adverse effects of doing this. It essentially shuts down the brain. You can think about on your computer that off button on the bottom of your hard drive that shuts everything down. That's what this does. It essentially decreases your brain's demand for oxygen, for any need for energy. The side effect is it can tank your blood pressure. It's very dangerous. Additionally, we don't like it as neurologists and neurosurgeons because it can take days to wear off. So even if I have someone in a pentobarbital coma, I might not be able to actually examine the patient for 2 days after starting it. So very dangerous. So a couple take-home points. While I understand that most of you probably will not go into neurosurgery, ICP management and intracranial pressure management is something that anyone in healthcare needs to be familiar with. Whether you're a doctor or a nurse, a physician assistant, a respiratory therapist, all of these people have to understand intracranial pressure and how to decrease ICP. It's something you're going to see no matter what specialty you go into. Again, we're all part of the team. All right, we all are taking care of the same patient, and it doesn't matter what part of the team you're on. It's something that you have to be familiar with. Now, something I want you guys to know, especially in your stage of your career, is that there are many things you can do to decrease ICP before you need to go to the operating room or give really powerful drugs to patients. Doing things just like keeping their head straight, keeping their head above their heart are easy ways to decrease the pressure inside of their head. And as a med student, if you're down in the emergency department, you see someone that has a head injury and you see they're lying down flat with their head turned, just lift the head of the bed up and turn their head. You greatly decrease their intracranial pressure just by doing those basic maneuvers. Again, remember your ABCs, all right? It doesn't matter if you're a neurosurgeon, a cardiac surgeon, a pediatrician, okay? Airway, breathing, circulation comes before anything else. So in conclusion, neurosurgery is a very challenging field. It's incredibly rewarding, okay? I can't imagine anything else I'd rather do with my life. My family makes fun of me all the time, but I'm the happiest person at 4 in the morning, waking up, going to work every day. I have the best job in the world. I get to treat the most amazing patients, and it's such a rewarding field. Again, we operate on the most fragile parts of the body. We operate on the brain, the spinal cord, okay? The most unforgiving parts of the human body and the most unknown. There's so much of the brain that we still don't understand, but that's what keeps us going, and that's what makes this field so amazing. Our field is changing so much. I showed you pictures of the exoscope before. There are new technologies every day. I'm working on a couple of grants right now, working on some new technologies that we're going to bring to the operating room. And we're really not scary. A lot of people are intimidated by neurosurgeons. They think for some reason that we're these like scary enigma people. But check us out. We have a ton of fun. On the left there is my co-resident, Abhi, who's awesome. In the middle there, I'm there with Alyssa, who's one of our physician assistants. She's actually in the operating room getting my patient ready right now. And then on the right-hand panel is me doing a shunt with one of my chief residents who's in the headlight. And then behind us is one of my best friends, Trevor. So, you know, it's really an awesome family. I love what we do. It's incredibly rewarding. And thank you guys so much for giving me the time. So come, you know, check me out. I'm on Instagram. I like to post a lot of things about neurosurgery and cool things that I do. I also have a really cute dog. He's a miniature dachshund, so you should check out his Instagram as well, because it's even better than mine, I promise. So with that said, you know, we can turn to some questions, you know, have people ask away. You know, nothing's off the table. Anything you guys want to know about me, either, you know, personally, the field of neurosurgery, getting into the field, whatever you guys have, you know, feel free, fire away.
Thank you so much, Dr. Schupper. This was amazing. Everyone loved how they just said they came in with knowing nothing, and you explained everything so thoroughly. They felt like they were experts at everything you were talking about. So thank you so much. We'll go ahead and let us know when you need to leave. We'll ask some questions until then.
Yeah, let's go for like another 10, 15 minutes.
Okay, so there was a question kind of towards the beginning when you were talking about your college experience, and we kind of talked about this before the session started, but would you say that playing a sport in college made you more competitive for medical school? Did it hinder you in any way? If you could kind of talk about your experience on that.
Absolutely. I can't stress it enough. Now, again, I don't expect everyone to be a college athlete, but for me, it was huge. Just learning, for me, starting in college, just learning those time management skills. I had to be at practice every day. We had 2 days in the weight room. Just being able to manage that with chemistry lab and organic chemistry was so important that it really made me hunker down in college and not just play video games all day like some of my friends, but really stay regimented, stay on a schedule, and that just carry through med school and into residency. And these are important values that I've really cherished that I attribute to a lot of the success I've had. But just being able to have time management skills and all these things, I think sports was really instrumental for me.
That's great. Thank you so much for answering that question. I think another question that we had was about research, and someone asked if they know that they want to go into research now in college, how should they look for research opportunities and where can they go out and seek those?
That's a great question. And it can be really challenging at times. It depends, A, where you go to school and what resources are around you. Um, I think it really depends on the person's situation, how much time you have. So I would say the worst thing you can do is to overcommit and underdeliver. If you're a busy college student and you're taking like 18 credits and 6 or 7 classes, I wouldn't commit to something where you're going to have to be in a lab for like 6 hours a day. I think that'd be pretty tough. But everyone that I've met in the field of neurosurgery is always looking for a hungry college student or pre-med student who just wants to learn more about the field. I mean, I'm always looking for undergrads to help write papers and stuff like that, just to learn more about the field. So you can always reach out to me. We always have a ton of stuff going on. We just submitted like 15 abstracts to a conference, and most of those abstracts have med students and pre-med students on them. So a lot of us are very open to doing it. But I think the best thing is just, don't be scared of rejection is the biggest thing. I reached out to so many labs when I was at Hopkins and got so many no's or no responses, but you can't let it get you down because it's not personal, right? Like there's nothing against you. I emailed Ben Carson just thinking I was like some hot guy, some like hot shot who could, get him to like do research for him, and he didn't respond, of course. And that happened with like 30 people, but I eventually found someone who was like, yeah, sure, why not? Like, I think it's cool you play baseball, come and check out my lab. And ended up publishing like 5 papers in college with him. So it was awesome. So, don't be scared of rejection. Just keep, shooting, cold calling, cold emailing people until you find something that hits.
Yeah, great. Thank you so much. I know a lot of us are always a little afraid of rejection. We had a really interesting question that was, can you explain the surgical differences between a child and maybe a more elderly patient, and how the differences with the healing process?
Yeah, sure. That's an excellent question. So anatomically, children and adults are very similar in terms of the brain and the structure. But what's not similar between adults and children is something called neuroplasticity. I'm sure you all have either heard of it or maybe seen some ad on some gimmick of trying to make you smarter. But neuroplasticity is real. And in kids, they have incredible neuroplasticity to the point that if you operate on a child young enough in their area of language, meaning the area that controls their speech, their area of speech can actually go to the other side of the brain. And it's wild. That can never happen in an adult. So the biggest difference is that the children, as ironic as it sounds, a child is much more forgiving in surgery than an adult is. And a child will recover faster than a lot of adults. And that's just because of plasticity. The brain rewires much faster and much more robustly than adults do. Obviously, children are very fragile just in general, but their brains recover in a much faster time course than adults does. And obviously everything's smaller.
Yeah, of course. Thank you so much for answering that. Also, there's so many people in the chat that said that you should definitely consider doing some academics and teaching later on, because you're really great at it.
Oh, thank you. I appreciate it. I'm always happy if you guys ever want me back or want me to give more lectures. I have about like 20 of these lectures that I can do.
Oh yeah, absolutely. Would love to have you back. That's no doubt. We also had a lot of people asking just about, the realities of being a resident right now. What's it like for you? How has COVID impacted it? And in general, how grueling it is?
Sure. No, that's a great question. And I know, on Instagram and stuff like that, we all sugarcoat it. Like I'm just going snowboarding, and then I'm doing Peloton and CrossFit and all this stuff. And, the truth is I do actually work, and I work a lot. And some days are really long, and it's not uncommon that I'm here till like midnight and then have to be here 5 in the morning next day. Again, that's why you love what you do, and you have to do this for the passion that you have for the human body and the people that you treat. Residency is tough. I mean, anyone who tells you otherwise is just lying to you. It's gonna be the toughest time of your life, but it's so rewarding because you're learning so much, and the number of people you can impact is so much greater than you can even when you're done residency. Because when you're a resident, you're covering all these different cases and all these attendings cases, and you only see the patient when you go operate on them versus the attending who has to see them in clinic and follow-ups, etc. So it's really amazing how many people you can impact on a daily basis. COVID has sucked. COVID really sucks, especially in New York City. So just a quick story. I was actually at Elmhurst Hospital, which now is like a commonplace name, in March, which Elmhurst Hospital is our level 1 trauma center. And no one knew it. It's this, small, really crappy New York City hospital in Queens. But ever since Trump called it out and they had freezer trucks carrying corpses in April and just horrible things, it's now one of the most famous hospitals in the country. So it was really rough. I was right down in the trenches when they didn't have PPE and we were walking into COVID rooms without N95s and all this horrible stuff. Somehow, miraculously, I didn't get COVID back then. And then a month ago, I got COVID and it wrecked me and it was rough. But actually today I got my second COVID vaccine. So I think I still have a bandage up there somewhere. Got it like a couple hours ago. So it's nice to finally be fully vaccinated. It's like a nice relief. So I'm very optimistic that things will go back to normal. I can't stress it enough, wear your mask, doesn't matter if you've been vaccinated. You have to think about the guy or the girl next to you. Just, social distance, be careful. Don't listen to the crazy people out there that say COVID isn't real. I've probably taken care of maybe like 50 or 60 people who have died of COVID so far. So it's definitely real. It's very humbling. It's very sobering. It's definitely been one of the most trying years of my life, just taking care of COVID patients. But at the same time, it really validates why we all go into medicine, right? Even though I'm a neurosurgeon, I've committed the rest of my life to operating on people's brains and spines. I mean, I did so much this year not related to neurosurgery at all, just because I was taking care of sick people that needed to be taken care of. At the end of the day, like, that's why we do this, right? Like, it doesn't matter if you end up going to oncology or orthopedics, right? We're healers at the end of the day. That's our primary role. We're doctors before anything else. And if there's one thing I want you to take home from this talk, it's that you're a healer and you're a physician before any specialist. It doesn't matter what organ you decide to specialize in. Your first job is to treat patients for whatever issue they need. And I think COVID has really embodied that.
Thank you so much for that honest insight. There's several actually people asked this question, and you're really into fitness and CrossFit, and then as a neurosurgeon, you stand for long hours, you use your hands a lot. Does that have any impact on like your spine, on your neck? Do you feel it in your hands or anything like that? People are just kind of wondering on the toll it takes on your body.
For sure. I mean, I think they work hand in hand. I think being an athlete is why I can stand for a 7-hour spine surgery and then want to do CrossFit after that. People think I'm crazy. Like, I'd routinely run 10 miles after spending 12 hours in surgery just because I love it. And it's because you build up this stamina and this endurance. It's what you want to do. And you see, it's the surgeons that are fat and out of shape and don't eat well and don't spend time on their health, that these are the guys and the girls who end up needing cervical fusions and lumbar fusions and back surgery, right? It's the athletes that take care of their body and that respect their body. They're the ones who are operating strong 20, 30 years into their career. Again, that goes back to being an athlete, that I always realize how important it is to be in good physical shape. And surgery, being a surgeon is tough. It's physically grueling. I don't know if any of you guys have ever watched a spine surgery or brain surgery, but when we're taking out a brain tumor, it often takes 4 or 5 hours. That's 4 or 5 hours under the microscope where your hands are like this and you're moving millimeter by millimeter and you just focus and you don't move. So you have to, there is a physical component to it where you have to have good posture and you have to have good core strength to just stand in that position for that long. So I think it works hand in hand. I mean, people are always making fun of me because I post like my Peloton workouts and stuff, but I attribute being able to have stamina in the operating room with being physically fit. And I always encourage my co-residents and my attendings, hop on the bike, get in a CrossFit workout. You don't need a gym. I just did a CrossFit workout in our call room like an hour ago. And you just need body weight. If you have a couple of dumbbells, it's great, but do whatever you can just to get sweat going. That it really works hand in hand, especially in medicine.
Oh, that's great advice. Thank you. Someone said they're actually watching this while they're on their Peloton, so we like to see that commitment.
Send me your workout. Maybe I'll do that ride tonight.
Someone asked a question. Have you seen an increase, or if you see this trend in neurosurgery in the future, an increase in diversity in the field, or at least how do you deal with distrust from people of color who are faced with significant health disparities that prevent them from seeking healthcare?
Yeah, it's a great question. I will say I'm very proud of our program here at Mount Sinai in that diversity and inclusion is a huge part of our health system. Last year, one of my chiefs is African American. This year, my chief is African American. He's Haitian American, actually. We have a very diverse group. We have people from Pakistan, from India, from China, from Colombia, currently in my residency group. We're very diverse. I think historically, neurosurgery has been like the white man game, like a lot of other specialties, but I think Mount Sinai and neurosurgery as a whole has actually done a really good job diversifying. We have a whole organization for diversity in neurosurgery. There's a whole organization for women in neurosurgery now, and neurosurgeons of color. So I think, we're moving in the right direction, but we're not there. I'm not going to pretend like I'm satisfied with the diversity we have in medicine in general, but especially in neurosurgery. I think it's harder in these really small subspecialties where, for example, in our program, we have 2 residents a year. So that's 14 residents over a 7-year period. So it's really hard to have a really quick change in terms of diversity and including people of all races and backgrounds when you only have 14 people. It's much easier in a medicine program, for example, that has 30 residents a year. In terms of disparities in access to medicine, I think that's incredibly tough. That's a huge unmet need that we have. I actually spent a lot of my time at Hopkins working in the public health department on disparities in surgery and actually how certain underrepresented minority patients in trauma don't receive the same care that non-minority patients receive. So for me, it's a huge clinical interest as well as research interest. I think there's a huge unmet need for improving diversity and inclusion in neurosurgery. But again, I'm very proud of our program that we spend a lot of time and effort on inclusion during the Black Lives Matter protests. We had all of our residency out in Central Park, which is across the street from our hospital, protesting. And we really have a proactive group here. So I'm really proud of the work that we're doing, but the job has not been done yet. And so I'm excited about the next decade and seeing, between now as a junior resident, when I become a chief, that hopefully will improve that.
Thank you so much. That was really great to hear. And I know a lot of people, it's a hot topic right now. And it's good to know that there's improvements being made. We know that you have surgery soon. So I guess we'll just wrap up with, as college students and post-bacs and master's students in this lovely little pandemic, what final advice would you leave with us as we hopefully end very soon?
Absolutely. Yeah, I mean, I can't wish it enough that this ends soon. No one wants this. But I think some final words is, continue to work hard, continue to grind. It doesn't matter if you're in person, if things are remote. I mean, really use that motivation. It's a lot harder now, obviously, in terms of resources. It's not so easy as a pre-med student to just walk into a hospital now with COVID. But then again, we have things like social media where you can listen to a neurosurgery lecture for an hour from your bedroom. So take advantage of those resources. People like me, I'm always looking forward to hearing from pre-med students, from med students, of how I can help them, how I can mentor them. There's so many people out there just like me. Martin Pham, who was on here previously, was a mentor in San Diego, and he's an awesome guy. And there's so many people in every specialty who are looking forward to hungry pre-med students and med students who are looking to advance their careers and go to the next level. So just bother us, just be aggressive with it. The worst thing we say is, hey, I don't have time, but most of us are pretty approachable and normal people. And don't forget that we were in your shoes not too long ago, right? It's not like I forget what it was like to be a pre-med student. So just, know what you want and follow your passion and don't be scared of rejection. Especially, things as challenging as neurosurgery, you can do it. You can find a way. There's so many paths that don't let anyone deter you. Don't let anyone tell you no. At the end of the day, like this quote on the screen, do what you love. Life is short. You have to have fun doing it. If medicine's for you, great. If not, do something that, that you want to change the world and that you want to make an impact. And, you never know how many days you have. So do something you love and something that you're going to be excited to wake up and do every day.
Thank you so much. That was awesome. Someone said you really made this session very accessible, and we completely agree.
Oh, good. Thank you.
And
yeah,
we
feel
hope
free
to have you back soon.
Yeah, please. No, message me on Instagram or message my dog. He's pretty cute too. And yeah, I'm looking forward to talking to you guys soon.
Thank you so much. Have a great rest of your day.
All right.
Good luck.
Take care.
Bye.
Bye.
Bye, guys. And then we will stay on for